Major support for these broadcasts is provided by the CUNY TV Foundation, New York Community Bank, Kilroy Architectural Windows, New York's window company, Capital One Bank, Perfect Building Maintenance, Chase Commercial Term Lending, Geneva Burns, Gian Tomasi and Webster, M&T Bank, the Wickoff Group, Chelsea Lighting, Greenberg Traurig, LLP. Additional support is provided by Ackman Ziff Real Estate, AKA Hotels, Corman Communities, Bank of America, Merrill Lynch, Bank Leumi, USA, Briarwood Organization, CBRE, Colliers International, NYC, Cushman & Wakefield, DDG, Douglaston Development, Levine Builders, Dime Savings Bank of Williamsburg, Eastern Union Funding, Flushing Bank, Friedman LLP, Herrick Feinstein LLP, Hersha Hospitality Trust, Investors Bank, New Banks, James D. Kuhn Real Estate Center at Syracuse University, James Orphanides, Centurion Holdings, John Katsimatidis, Red Apple Group, Margolin Weiner and Evans, Madison Realty Capital, Meridian Capital Group, Newmark Grubb Knight Frank, Popular Community Bank, SJP Properties, Sterling & Sterling, Stonehenge Partners, Urban American, and these friends.
Healthcare. I mean, we have an Affordable Health Care Act. We have many people who are going to be insured who have not been insured, maybe 30 million. Where are we going to take care of these people? Who's taking care of them? We have to have physicians. Who's creating this area of new students in medical schools? So today and next week, I have a two-part section on the subject of training the next education, the next generation of healthcare professionals. And I'm very fortunate that I have the leaders from some prominent medical schools here to provide their insight. My guests include Dr. Alan Spiegel of the Albert Einstein College of Medicine of Yeshiva University, Dr. Dennis Charney of the Icahn School of Medicine of Mount Sinai, Dr. Edward Halperin of the New York Medical College, and last but not least, the newest medical school, Dr. Larry Smith of the Hofstra North Shore LIJ Health System. So we were talking before, since you're all deans, and we were talking about generations, because the week before I did a show with generations. How did you decide to become physicians?
It's a great question. Of course, the cliche is that every Jewish mother wants her son to be a doctor, and mine was no different. And in fact, that relates to the founding of the Albert Einstein College of Medicine. Hard to imagine in this era of political correctness, but Jews were discriminated against, weren't able to get into medical school, there were quotas, and a group of visionary individuals, and the president of Yeshiva University, Samuel Belkin, created the Albert Einstein College of Medicine.
You know what's very interesting? In essence, you're the oldest medical school here, okay? I believe
1860.
1860. Albert Einstein was
55.
55. You were 72, right?
Well, we graduated the first class.
It was 68 was the first class, because Ken was part of the first class with my friend Rich Bernstein, and you're the baby. You're in your second year over here. So did you want to at the beginning? You always thought you wanted to be a physician?
I really was always interested in science, biology more than physics, and medicine as a profession, the opportunity, really the humanism of it, the compassion of it, and yet rooted in science. And so that was, for me, perfect.
So with me in ninth grade, they asked, what did you want to be? And I said, number one, a pro basketball player. Number two, a basketball coach. And number three, a doctor, because my mother wanted me to become a doctor. I was a good basketball player, but I gradually realized I was not going to be a pro, and medicine started to appeal to me.
Ed?
I wanted to be a civil rights lawyer. My goal was to be Nicholas Katzenbach and desegregate the universities of Alabama and Mississippi.
And Larry?
So I studied physics first, and one day decided that, in fact,
Right, you went into medical school later on in life. I think you were
I did
29.
physics and then graduate work in biophysics, and ultimately really decided I wanted the combination of people and science.
Now, it's very interesting. We were talking prior to the show that both of you have sons who now are physicians or medical school, correct?
Yes.
But that's not a phenomena. That's something that has happened over the years. You were saying to me, it's a tradition that many fathers, fathers and mothers, their children become physicians. Do you see that, Alan?
We see it at Einstein. Every commencement, we have the hooding ceremony.
But do you see that continuing? Because healthcare has changed so much.
Yeah, we see.
The business of healthcare may have changed. Has healthcare changed in your mind since you graduated, all of you, medical schools?
Enormously.
Okay.
My specialty is the care of children with cancer who need radiation therapy. When I started, many diseases were uniformly fatal. The cure rate has increased enormously in my lifetime. In many ways, I'm sorry I won't get to see what happens for another 40 or 50 years to watch the trajectory continue.
Medicine has changed in terms of the advancement in science. That makes it so very exciting. The business is more complicated, but I think the rewards are the same in terms of the ability to help people and discover new things about it.
Let's not forget also just the demography of who's involved in medicine. I went to a medical school class at Harvard which had maybe 10 women in a class of 150. Now it's equal, 50-50, and I think that's had a profound impact.
But I also see that, looking at your class, your first class was 40. The
Yes.
second class was 60. The third class is going to be 80. And I was looking at the age of some of the students. You had one student who was 46 years of age.
Yes.
So, it's a different world. What's the age of the students at your school?
Nationally, about 1/4 of American medical students, when they enter, are 27 years of age or older, and our college would be similar. And these are
But do we
called-
have the 40-year-old entrants? I remember when I was teaching and the treasurer of the College of Podiatric Medicine, I had a lot of older students, but they were traditionally Russians who came over that weren't able to get into a medical school, or they may have even been a physician in Russia or from a foreign country, and they went there because they wanted to get into the healthcare
The
profession.
type of older student has changed. When many of us were in medical school, the common story was, I'm a military veteran, I've come back from Vietnam or my service, and now I'm going to go to medical school. You have far more older students who said, I did something else in life. I was an accountant, I was in business, I had a family to raise. Now I've consciously decided to go to medical school. They were driving the timing rather than the military.
The older student is, I think, still a relative rarity. What is now, I think, a significant change is the idea of going immediately after college and entering medical school. That's now almost
I think
unheard
that
of.
has really changed.
So at least a year, and in some cases a bit more, and of course that extends.
So
the
you're
entire period.
saying, somebody should take the 1 year off?
I'm not prescribing.
I'm not
So
saying,
I
I'm not
don't think we're
prescribing it.
seeing students that actually take it off. They do very productive things, sometimes while still deciding whether or not to go to medical school, although I think underlying is a desire to do so. But they do real things and not necessarily always medically career advancing. They often teach, they'll work overseas. It isn't a year off the way you might think.
But all four of you went to medical school and spent 4 years at medical school, correct?
Correct.
Right now, I believe NYU is trying to do a 3-year program. Then there are certain programs. There was a 6-year program or something at certain institutions. Do you believe medical school can go into a 3-year program?
Well, during World War II, most medical schools were 3 years because of the needs of the military. So, and the statistics on the outcome of physicians trained during World War II shows successful education and practiced as well as others. So it's not a new idea, then went from 3 years back to 4 years after.
The trend in medical education is to move from time served to competencies. And I think it's challenging for us. It's challenging in graduate medical education, which is residency, and in undergraduate medical school to assess those competencies. But that's really the crucial issue. So in other words, it may be that for one individual, 3 years is all it takes to get the competencies. For another, it may take more. I think that's going to be a challenge for all of us, but it's not going to be a cookie cutter one size.
But I would say, we're not in favor at Mount Sinai in reducing the time, that there's more and more knowledge, there's more and more science.
Right, and I think what Ed was saying, you know, the learning curve, and you know, when he started in practice, you know, if you had cancer, it was a fatal disease.
I mean, in fact, what I was going to say also is that, and I think this is true of a lot of the other schools, more of the students are taking a fifth year, that they're taking time off to do research. In some cases, they're taking time to have a global medical experience. So instead of contracting, more and more students are taking a fifth year for those purposes.
Nationally, about 10 to 15% of U.S. medical students graduate with a dual degree.
There have been dual degrees, you know, the MD, MPH has been one major dual degree. There's been the MD, MBA as a dual degree. There have been other master's in science degrees over there. What do you see as, which major degrees, dual degrees are you seeing today?
So we see the MD, PhD, which is very important, and the NIH helps support that. That's usually done during the context of the classroom training. It's an 8 or 9 year program. We are now orienting toward a MD then getting your PhD, so that you get your PhD in the area of training. We think that might be an optimal way to train physician scientists.
So what happens? You have the 4 years, and when do you decide that you're going to get your
This would be PhD.
PhD?
That, say you decide you're going to become a cardiologist, but you want to be a physician scientist, a cardiologist who does research. We think getting your PhD in the context of your cardiology training can prepare you for a longer-term career studying, you know, the heart.
So we actually, even as a new school, offer both of these programs from day one. The classic MD, PhD integrated with medical school, and a PhD as part of your specialty fellowship for those people who want to be physician scientists.
We have one of the longest running NIH-funded MD, PhD programs. And what's striking...
Explain to my audience
what it is.
What is the NIH-funded program? Because I think the NIH is very important, because the NIH funding helps the education.
Let me take a crack as a former director of one of the big institutes, the National Institute of Diabetes, Digestive, and Kidney Disease. The NIH is really a gem. The late Senator Arlen Specter used to say it's the jewel in the crown. Some say the only jewel in the crown of the federal government. He was an enormous supporter, because really NIH has supported the fundamental research which industry and private sector never would fund, and it's the underpinning. You heard President Obama say in the State of the Union message that for every dollar spent on the Human Genome Project, it's generated $140 in economy, in business, and that was NIH supported. So it's vital to us. It's vital for training programs like these MD, PhD programs, but it's vital for the research, particularly in the research-intensive schools.
What happens, you know, with budget crisis, other situation, on funding for these NIH or other programs?
So we're all facing this, particularly the research-intensive schools. The sequester is resulting in up to a 10% decrease in the funding of NIH grants, which results in literally that in order to get a grant, you've got to be well in the top 10% of all people applying, which means 90% who apply are not getting grants. That is very demoralizing, and especially during a time when the science has never been stronger. It doesn't make sense.
I think we need to tie this in, not just to the economic value, which I alluded to before, but to the healthcare system. If we're going to have a prayer of really surviving as an economy in terms of the healthcare system, we need fresh approaches to things like Alzheimer's disease. It's really unsustainable to have a tsunami, as it's been termed, of baby boomers getting Alzheimer's and getting the kind of care that they need, which is really ineffective fundamentally. It's really only basic research, and at the other end of the spectrum, autism. This is a huge unmet need. Unbelievable.
I believe that I've never seen so many people, such an influx of autism. I mean, since we're all relatively contemporaries, I mean, when was this autism? Years ago, was it here, or has it increased?
I could take a crack at that, being a psychiatrist. So when I was in training, autism was considered a rare condition. And now, you know, the recent epidemiologic estimates are up to 1 in 90 children have some form of autism. People are wondering, does it mean we're making a better diagnosis? We're more accurate in our diagnosis? I think that is part of the answer, that we were calling it something else and it really was autism. But there may be environmental causes that we haven't identified, and that's an active area of research.
Yeah, we should be very clear that all the stuff about mercury in vaccines is not the reason. There's rigorous data about that. There's soft but suggestive data about the age of parents, and not just the mothers, but also the fathers. People, now that doesn't mean that people shouldn't have kids at that stage. It's still a rare statistical phenomenon, but that may be one of the reasons. And surely, as Dennis said, better diagnosis. It's a spectrum, by the way. So, even subtle changes are now being diagnosed.
I want to give an example for your viewers. What's the NIH? In 1963, Jacqueline Kennedy gave birth to a baby who died of prematurity. The president's wife receiving the most outstanding medical care, that baby died. Today, that baby would have close to 100% survival, and that's the result of the NIH and federal research. That's a concrete example. Something which was considered uniformly fatal was cured by government effort.
This is a wonderful example. We're proud that our new chair of pediatrics, a woman named Judy Ashner, coming to us from Vanderbilt, literally the end of this month, is one of the leading neonatologists in the country. And it's exactly these kinds of changes. And in fact, the outcomes of these kids are quite good.
There, as I'm hearing there, it sounds like there are many new different phases of medicine, medical practices, and subspecialties or that didn't exist 30, 40 years ago, correct?
Absolutely.
Sure.
Yes.
I mean, you're in New York. Pediatrics in America started in New York. There was no pediatrics until the 19th century when Jacobi started it. Medicine has always been spinning off and creating new bodies of knowledge for specialization.
So let's talk about specifically training of education. You have right now, as we said, you started with 40, you have 60, then you have 80, then you have 100.
Right.
You have 196
Yes.
medical students. You have 146.
140.
140.
183.
And you 183. Every 6 minutes, another baby boomer gets to be 65 years of age. The longevity of people is increasing each and every day. As I started at the beginning of the show, 30 million people are going to be covered under the Affordable Act. How do we take care of keeping these people healthy and alive?
Yep. Yeah, so, as we were talking about before, there is a physician shortage. A number of new medical schools have come online that will train more doctors. Those of us who have had medical schools for a while have generally been limited in terms of the size of our class by the ability to find high-class rotations for them in our hospitals.
But didn't we bring up the fact hospitals are shrinking? The Becker report was, to reduce the number of hospitals, okay? In the New York City market, we have seen the reduction of at least 6 or 7 hospitals. Before you came here, okay, St. Vincent's was a hospital system. They're no longer here. We have this consolidation of systems, so we have a different case.
As we discussed before, we also need to be adaptable and flexible to a model that's going to have more training, and this is more labor intensive, more costly and more difficult in an ambulatory outpatient setting. That is, I think, the wave of the future. After all, most medical care doesn't take place in the hospital, and hospital stays, by the way, are decreasing shorter than ever.
I mean, let's be careful not to fall into a trap. You said 30 million people, how are we going to take care of them? The most effective way to take care of them is to keep them from getting sick in the first place. So that you are going into a format of a disease response system where it is more effective to have a disease prevention system. And that's about tobacco control, diet, alcohol, exercise, environmental toxins. Medical schools training physicians are one approach to the problem. Proper public health work and prevention is a far more important and more cost-effective
I also
approach,
think
yeah.
we're moving to team care. And I don't think every piece of the care of us baby boomers who are going to retire is going to take place by physicians. Nor should it.
I've been reading a number of articles getting prepared for this, and that is part of the discussion, that you will have the role of the nurse practitioner doing more work over there. There'll be more people doing subspecialties to take care of some of the practice. Let's talk about telemedicine.
I just want to add one other factor that I think is important in relation to your question about more, subspecialists. A very positive outcome of the Affordable Care Act will be more primary care doctors. and almost all medical schools now are preparing our medical students to become primary care doctors. That will improve wellness because that is a focus of our primary care doctors. So that will help a lot with the increased number of patients who now can afford care. They'll get their care initially with the primary care doctor and not go directly to a specialist.
Why do you want to become a primary care physician when you can make more money if you're a specialist? I mean, the articles are blunt. You know, hey, a primary care makes $150,000 after residency program, while a gastroenterologist or a subspecialist makes $300,000. Plus, as we said prior to the show, there is a lot of tuition that has to be paid off. And if you take an average of $45,000 to $50,000 for each one of your students, that to me is $200,000. And then if they have undergraduate, they could be at $300,000.
It may be surprising and a little counterintuitive. Our education dean, Dr. Martha Grayson, she's actually done some fairly rigorous studies on relationship between indebtedness of students and specialty choice. And yes, there is a threshold, probably above $250K, they're not going to go into primary care. But even students substantially indebted, still, it's a question of altruism, it's a question of lifestyle. I think there are a number of choices that go into this.
You know, I think what you're alluding to is us creating a system during training that makes people follow their passion and not their wallet. And I think that is critical. And one of the things that I personally think is an issue is not so much that primary care doctors are grossly underpaid, although I think there are times when paying off debt can really become a problem. But the difference in income by specialty is so dramatic in this country compared to any place else in the world. You know, I entered practice in the early 1980s, and the difference between a primary care physician and the most specialized surgeon was maybe 30–40%. And now it's 600 or 700%. Now we're talking about enormous differences in terms of the choice of what you're going to do in your life.
I hope my colleagues don't assault me for saying this, but let me be blunt. Fee for service, I mean, this is really the elephant in the room, and I think we should address it. It is essentially going to disappear. So just so we're clear, fee for service is the prevalent method of compensation, whether it's third-party insurance or the government in the form of Medicare. It's really piecework system. And hence the gastroenterologist doing endoscopies and getting remunerated. What's going to happen instead, and we talked about Montefiore and Steve Saffier at CEO, they're way ahead of the curve. Basically, the idea is a capitated level, and finding that cost is important. So covered lives.
That is the Bronx. And
it's not, bear with me, it's not just the Bronx. Let me take issue with that. It's not just the Bronx. There's something called a Pioneer Accountable Care Organization. There are 14 in the country. Yes, the Montefiore Medical Center is one of those. Guess what another one is? It's called Partners. That's the Mass General and the Brigham. That's not the Bronx.
No, I agree.
They are because they see the writing on the wall.
Alan, I'm not disagreeing, but in New York City, I recently had hernia surgery, and I'm not sure if the surgeon was joking with me or not. And I said to this doctor, I said, I really don't want a complication. And his comment, and I think partially he wasn't kibitzing, was, you know what, your coverage isn't the type that I really want you to come back. And that was, I'm not even mentioning the institution where it took place. Yeah. But I believe that in many ways.
Here's where I agree with Alan, and I think we all agree on this, that times are changing. And that fee-for-service is going to gradually disappear. It's about population management. The Affordable Care Act is forcing us in that direction. Primary care is going to become more important. Wellness is going to become more important. And the disparity of pay between primary care and high-end tertiary care surgeons is going to reduce over time.
Yep. There's a very interesting economic analysis of what Dr. Charney is saying is, if you look at the ratio of countries of the developed world of the average income of a physician versus the average wage earner's income, the United States ratio is much higher than most other countries. Americans didn't begrudge their doctor when the average citizen drove a Chevy and the doctor drove a Buick, but when the average citizen drives a Chevy and the doctor drives a Maserati, then there will be a political pushback, and that's what we're seeing.
As I used to tell my students when I taught at the dental school, a business course, and dentists have a different case because many of them didn't go to residency, or if it was a 2-year residency. And I would tell them, I'd say, if you have the Cadillac, you drive the Chevy to the office, and that's the car that you show your customers, especially in the blue collar neighborhoods. And they agreed. Some of my students learned that situation. But you talk about the changes to your institution just came up with Minute Clinic, okay, with the telemedicine approach, and there's a big treatment of there's the doc in the box, as I would call them, have changed over there. I mean, which physicians that you've trained are going into the doc in the boxes or the retail medicine centers? Do you see?
Very few in our institution.
I don't know of any.
The idea of social justice and equal care is becoming more pervasive in medical school. That I think the humanistic approach to medicine is coming back as opposed to the doc in the box.
And at the same time, the humanistic for sure, and at the same time, I think this is where you were going maybe with the telemedicine. Technology is having a dramatic effect. I mean, the students of the current generation are arguably digital natives as opposed to the rest of us digital immigrants. I mean, they have grown up with this and they're very comfortable with it, and it can have a profound impact. When I have our incoming class and I show them, a classic photo of the physician at the bedside, looking at the patient, you don't want them
Marcus Welby. Okay.
Yeah, you don't want them looking just at the computer monitor. On the other hand, we have to harness the technology. Just the power of cell phones, just the power of interacting with the patient. Diabetes is a prime example. They actually can control their blood sugar and something called the hemoglobin A1C, which is a measure of blood sugar control. And as Larry pointed out, this isn't just a question of physician interaction. It's the entire team that can care. That's what's called secondary prevention. Ed pointed out primary prevention, very important. Unfortunately, you've already gotten diabetes, but you can prevent the dread complications with this kind of more holistic approach.
Exactly. So, you can magnify the efficacy of physicians. So we do telehouse calls for people with heart failure. We do telepsychiatric consultations in emergency rooms at hospitals that cannot possibly get 24/7 psychiatric staffing of the ERs. And this is unbelievably helpful.
We're going to continue this conversation for our show next week, but I'd like to thank the four of you and Dr. Alan Spiegel, Dennis Charney, Ed Halperin, and Larry Smith, and we'll be back next week.